Good morning. Good morning. Okay. Yes, okay. Good morning. My name is Tamara Huff. I'm an orthopedic surgeon down at Mayo Clinic Health System in Waycross, Georgia. So I'm in that blue zone that we talked about earlier. I'm in Southeast Georgia, down in the corner down there. I do my research with women in African American communities in Waycross, Georgia, but I also work with the Mayo Clinic Health System in Jacksonville, Florida. We look at some community-based interventions that we can do that are culturally competent. So my talk today is more about the importance of how I keep you moving, okay? I think every talk today has talked about the importance of movement in your mental and physical health and your cognition. So now we're going to talk about how do we keep moving? What can I do to keep you from fracturing, to keep your knees feeling better, to get you off that cane and keep you moving, okay? Okay, so when we talk about that, there's two things that really I see all the time. So fractures. And one of the main reasons why my ladies get fractures are osteoporosis and vitamin D deficiency. So just for show of hands, who's broken the bone in here? Okay, so I think this is definitely something that we're going to talk about. So we'll be talking today about osteoporosis. What is it? Who is affected, and how do we prevent it? Then we're going to talk a little bit more about knee pain, which is something I think just about everybody will raise their hand for, me included. There you go. All right. So osteoporosis, again, what is it, who gets it, and how do we handle it? Okay. So osteoporosis, when you break the word down, osteoporosis is Greek for porous bone. So you can think of your bone as being a sponge that's just too thin when it becomes osteoporosis. So if you look at the image on the left, that's healthy cancellous bone or spongy bone. On the right, you notice there's not as many connections between the bone. It's more what we call spiculated. That is what osteoporotic or thin bone is. So basically, you're losing the density of your bone. Now, when you lose that density, that can be because you're not making enough bone, you're not laying it down like you should, or your body is resorbing it. So bone is alive. You don't have the same bone at 50 that you had at 10. You may not have the same bone that you had at 20, okay? Your bone is constantly remodeling itself. It's one of the few things in your body that actually can heal itself. And that way, we're kind of like starfish, okay? So when that gets dysregulated, that's how you get osteoporosis. So who's affected? Many, many people are affected. So again, this is an international problem and a national problem. So 54 million Americans and approximately 200 million people worldwide are affected. Again, about 30% of postmenopausal women in the US and Europe are affected. 1 in 3 women and 1 in 5 men are at increased risk of osteoporotic fractures. Now, when we talk about osteoporotic fractures, people classically think of hip fractures. That's what I do, lots of hip fractures. But there are other fractures that we consider fragility fractures or osteoporotic-related fractures. Wrist fractures, shoulder or proximal humerus fractures, compression fractures. When we lose our height, many times that's coming from compression fractures. So you have to step back. If that's happened to yourself, to your mother, to your father, are they being screened properly? Are you getting a metabolic bone workup? And we'll talk a little bit about that. Those are key things because we know you have that shoulder fracture, you're at about 50 to 60% higher risk of a hip fracture in the next 6 months. And that is a major change in your life, having a hip fracture. That's the number one thing I want to prevent. There you go. So who's at risk, okay? And when we talk about non-modifiable and modifiable risk factors, there's certain things we just can't change, okay? My father is actually a mortician, so when we talk about alternatives, so I say that to say in our family we have lots of jokes about that, but one of the big things is You only have two choices. You know, you either get older or the alternative, and it's not too great. So we can't change the fact that we age. It's just a fact of life, okay? We can't, female gender, that's a risk factor. Family history of osteoporosis. So again, if your mother or your father has a hip fracture or a compression fracture, you need to be keeping in mind, are my bones strong enough, okay? Menopause, we just talked about. Low body weight. So this is one of the cases where there really is, you can be too thin and you can be too large. We always focus on obesity, and we will talk about that. But there is something to be said about being too thin. And the thing we need to focus on is being well nourished, okay? That's the most important thing, being the healthy size for our body type. That's the most important thing, okay? And again, we talk about broken bones leading to height loss. Things that we can change. So vitamin D deficiency and calcium, okay? Many people are vitamin D deficient. Even though we're in the South and everyone talks about getting vitamin D from the sun, we're not out in the sun enough. We are not. I'm in South Georgia, burning up, and still not getting enough vitamin D, okay? Not getting enough, okay? Also, too, calcium. So many people are lactose intolerant, and we'll talk about incorporating calcium into your diet. That's key. Sedentary lifestyle, so we want to make sure we're moving. I love John Lewis's moving around in the chairs. That's amazing. I need to have him like before every presentation and in my office waiting room. It's important. Yes. Also, too, smoking. So in my community in Ware County, over a quarter of our population smokes. And it's probably higher than that right now, okay? Smoking is the #1 modifiable risk factor you can do that will make your life better, okay? A lot of people don't realize smoking affects your ability to heal. If you smoke and you have a total hip or a total knee, you're not going to heal. Your risk of infection is greatly increased. So again, things to keep in mind. Excess alcohol consumption, again, that can affect your ability to absorb the nutrition that you need. And then losing weight, so talking about that healthy weight. Okay, again, diagnosis. So when you're concerned, if you've had a fracture, you have a fracture in the family, if you're concerned, have I been worked up, you need to get a DEXA scan. What a DEXA scan, also called a bone density test, is measuring how thick or how thin your bones are, okay? And again, we can go into the specifics, but there's normal osteopenia, just means you're getting kind of thin bones. Osteoporosis means they're thin. We need to talk about treatment. And then severe osteoporosis, so you're less than 0.25, and those are standard deviations, meaning comparing yourself to a normal person in your age group, plus one of the fragility fractures that we also talked about. There's also a FRAX assessment tool that you can go online, and it takes into consideration what your ethnic background is, what country you're in, on whether or not you need to have additional workup done. So again, treatments. I am an orthopedic surgeon, but every time you break a bone and you come to me, we're checking your calcium level, we're checking your vitamin D level, and we're going to talk about doing that bone density test if you haven't had it done within the last year. But one of the big things you can do is just making sure you're getting enough calcium. Vitamin D, we'll talk about the types. Fall prevention. So that's, again, where that exercise comes in to play it, and making sure your core muscles are nice and strong and your balance is good. Exercise and balance programs, again, and actually hip protectors, which look kind of like thigh pads from football players. They actually, if you do fall, they protect you from breaking something. So we'll talk about those. Those are kind of snazzy. Prescription medications. Now, these are medicines that some orthopedic surgeons that have fracture clinics will actually prescribe these. In actuality, the only one I prescribe is calcitonin up here, which is excellent for back pain after a fragility fracture. But we also talked about hormone replacement therapy, question about that, SERMs, and bisphosphonates. So bisphosphonates are the frontline treatment when we talk about osteoporosis. And there's some pros and cons to that, and we'll dive into that a little bit more. Also, something called anabolic agents, parathyroid hormone. You may have heard it as Forteo. Forteo is one of the few medications that actually can help you build bone. Many of the bisphosphonates that we talk about don't really build the bone. They actually help you from breaking the bone down. Like Fosamax, excuse me. So an example of common bisphosphonate is Fosamax, okay? So non-prescription medications, again, calcium is key. You should be taking in about 1,000 milligrams to 1,500 milligrams. That goes up if you're trying to lay down bone. And just for reference, 300 milligrams of calcium is in your glass of milk. So one of the things I recommend, a lot of people say they get upset stomach, lactose intolerant. Calcium citrate is excellent. Grab some Tums. Take a couple of Tums. That can help out a lot. Vitamin D deficiency. So classically, when we talk about vitamin D levels, our endocrinology colleagues normally say you want to be around 30. I actually like to see my ladies above 45 because some of our studies out of orthopedics and our physical therapy colleagues show that you have improved balance and coordination along with bone healing higher than 45. So again, it helps with your absorption of calcium, and there's different types, and that's something that your primary care doctor can go over with you. But ideally, I tell folks, go to your Kroger, go to your Publix. You want to get vitamin D and calcium together twice a day. Stop smoking. Please stop smoking. Stop everybody from smoking. It's the number one thing that you can do for your health, okay? Limit your alcohol intake for a healthy amount, and fall prevention. So again, exercise is important for balance and coordination, and also gaining lean muscle mass. And we'll talk about that. That's very, very important when we talk about knee pain and knee osteoarthritis. Having increased muscle mass helps your knees feel better, okay? Also, too, environmental modifications. So you want to go around your house and look at fall risk. Those rugs, watch out for the rugs, please. If you're at your house and you have a low toilet, be mindful of that. That's very, very commonly people fall in their bathrooms. They fall getting out of the shower. They fall pivoting. Be mindful of those things. You know, there are resources. There are home health people that can come out. You can speak with your doctor that can show you, hey, this isn't the safest way to handle things, okay? And hip protectors, which again, just look like the football pads that go, they actually can go underneath your clothes. They're terrific. They kind of help you bounce off things. I just think they're great. So everyone asks, what happens if I break a bone? And you have to come see your friendly orthopedic surgeon. So one thing we'll talk about again is we'll check your calcium and vitamin D levels, and again, we're going to increase the amount that you're taking to again help you lay down the bone that you need. Bisphosphonates, otherwise known as Fosamax, medications like that, if you're already on them and you break a bone, we oftentimes will tell you to continue to take it. Now, you will heal slower, but the bone that you lay down is of higher quality. So that's something that many times, if I see you're on Fosamax and heaven forbid you break something, then I say, hey, let's keep going. That's okay. Forteo, teriparatide, or Forteo, that's one of the few ones that actually can lay down bones. So many of our colleagues, the orthopedic surgeons that work on the spine, are actually putting patients on Forteo before surgery, so your bones can get stronger, so you can do better and heal your surgery better. And I can answer you some more specific questions afterwards about those. So we've talked about osteoporosis. Now let's get into knee arthritis. So can you raise your hand if you have knee pain right now? All right. So many times, many things can cause knee pain, but the most common reason why is for knee osteoarthritis, okay? Okay, there you go. So again, when we talk about arthritis, most common type of arthritis is osteoarthritis. So when I mention arthritis today, that's what I'm referring to as osteoarthritis. There are all different kinds. There's rheumatoid arthritis, there's inflammatory arthritis, all other ones. But we're not going to talk about those because they're a little different. We're speaking on osteoarthritis, which is the most common type. Now, that's the one where we talk about the wear and tear on your joints. But it's not just that. It's also obesity. It's also your age. It's also your sex, your family history, especially with hand arthritis. So if your mom had it, that's the gift that keeps giving. You're going to have thumb arthritis. It runs in the family, okay? Race, we see African American women have arthritis patterns that are a little different from their white female colleagues. And also, too, history of trauma. So if you've had a knee injury in the past, an ACL tear, the risk of you developing arthritis is much higher. So again, just so you know, if you haven't ever seen an x-ray, right there, and that one actually projects well. That is what arthritis looks like on an x-ray. So all arthritis is you've worn down that nice smooth cartilage that doesn't have nerves in it or anything. You've worn that out, and now the bone underneath it is exposed. And that's where the inflammation comes from. That's where the swelling comes from. That's where the pain comes from. That's why it hurts when you sit for too long. So listening to me, that's why it hurts when you go to stand up. It's because that nerve has been exposed to those fluids for that long. So one thing is arthritis disproportionately affects women at every age group. So the lines that we see here is the rate of arthritis is 58% higher than for men. So women, again, is in blue. Men is the hashtag of the red line, okay? And then again, you can see it persists all the way through age groups. Now, this is where we talk about obesity, but also muscle mass and that link between that and arthritis. So the higher body weight you have, the more forces you have across your joint. So your knee basically has a fulcrum, or your kneecap is a fulcrum for your knee joint. So every time you gain 10 pounds, your body sees 3 to 6 times your body weight just walking. So walking 3 times your body weight, stairs 6 times your body weight. Heaven forbid if you try to kneel down at church, that goes to 10 times your body weight, okay? That's why you can't go to altar call, okay? That's why it hurts so bad, okay? So that's why your body is seeing more weight, seeing more force across it. That's no excuse for not going to altar call, I'm sorry. Never excuse. So, but again, the ways we can stop that or to slow it down again is increasing your lean muscle mass, because when your quadricep muscles, which are your thigh muscles here, are stronger, they take the pressure off your knees. That's one of the things we talk about, your hip adductors or your thigh muscles being stronger, okay? One thing we see again is you losing that lean muscle mass is directly correlated with increased knee pain. And again, we mentioned the topic of BMI. Again, BMI is just weight divided by height, okay? And that is kind of gets thrown off a little bit with athletes, okay? But again, in the U.S., over 2/3 of Americans are overweight and 1/3 are obese. Now, next slide. Okay. Now, this is data from the CDC, and most of you guys have probably seen this. This is from 2011, okay? So we're down in Georgia. We're nice and yellow. Since then, if you look at the 2014 data, we're definitely orange, if not red, by 2016. Now, keep that in mind, and let's look at, or maybe not look at. There we go. Let's look at it for African Americans, okay? So this map is for African Americans. Now look at the difference. Now red on this map is over 30%. So you can't really see it, but it's over 35% of African Americans in that red zone are obese. Now, that's a big problem. We just talked about that's one of our main risk factors for knee pain and knee arthritis. So what can we do? So, and again, African American women, 54% of African American women report as having doctor-diagnosed arthritis in the past 5 years, and compared to 37% of white women. Now, one thing in orthopedics right now we're looking at is the importance of excellent outcomes. What we know is if you have worse knee pain before surgery, so if your pain is a 10 out of 10, I can do the most perfect surgery. I'm going to get you down to about 4. But if you come to me when your pain is just a 6 or a 10 or 7 out of 10, I can get you down to a 1 or a 2. So your outcomes aren't as well as your male colleagues would be, or fellow patients. Now, where that's important is nowadays physicians are being paid by outcomes. Now, guess what? I look around and I know women don't do as well with knee replacements as their other male patients do. Black women especially, the studies are coming out, aren't getting outcomes as good because we wait longer to have it done. So what happens? We start cherry picking patients and dropping lemons. So keep this in mind. We want to advocate for the best health for ourselves, for our mothers, for our daughters, for each other. And this is very, very important. So there's a cycle here, okay? Movement is key. And movement, when you lose movement, you increase your joint pain. You have limited mobility, which leads to lack of physical activity, leads to obesity. And the smaller circles, the heart disease, the diabetes, depression, those are key factors. And we know if you're depressed, you have more pain, you don't do as well after your surgery. We know that if your diabetes is out of control, you don't heal, you don't do as well after your surgery. So these are all things, but at the center is always movement, okay? And again, obesity is an independent risk factor for increased pain in the elderly, okay? And again, we've talked about abdominal obesity. Another one of those issues is your core muscles. When your core muscles are nice and strong, meaning your belly muscles here, it supports your back. It helps decrease back pain. So what do? I've scared you half to death, so what do? What do we do? Okay? And that's what my patients are like, oh, Jesus, this tough way to be done. So what do? So we talk a lot in my office about weight loss, eating healthy. I'm born and raised in the South. I'm from Columbus, Georgia. I love my fried chicken, but you eat it in moderation, okay? Everything in moderation, okay? And the Mediterranean diet is key. Really, exactly what our last speaker was talking about. 10 extra calories per day, so that adds up to around 500 calories a week. That can make and break you on losing a pound versus gaining a pound, and that's key long term. Exercise programs, so again, for everything from the chair, I actually teach something called Funky Fit 50, so this is from Nettie Reeves, and we dance around, we do songs to Mary, Mary, and all kinds of things, but it's all very protective to your joints. So whatever your thing is, get out there and move. So I tell people one of the biggest things is aqua aerobics. You don't have to swim, just walk in the pool. That's key. You do not have to feel like you have to swim. So find something that brings you joy because it will make you mentally better as well as physically better. Also, too, anti-inflammatory medications are one of the first lines. We can't reverse arthritis yet. We're on the cusp of it, but we can't quite do it yet. If you start those anti-inflammatory medicines, please reach out to your primary care physician and make sure they know that you're on it because there are a lot of other side effects that can happen, and many times people don't follow up. Injections, there's two main kinds that we talk about. One's a steroid, which helps calm down the inflammation. The other one's the fancy term viscosupplementation, basically is gel. We're trying to nourish the cartilage you have left, and we can ask specific questions about that. All in all, surgery is the #1 way to take care of arthritis. There's some joint preserving procedures, but by the time you get bone on bone, we're talking about a total knee replacement. And that's actually what your total knee replacement looks like down there. It's actually a resurfacing. Many people think that we cut off the ends of your bones, and we do not. We just put metal caps on either one. So yes, we do not amputate your bones. It's still your own ligaments, and we can talk about those things if you have questions. So I do research, again, on African-American women and knee pain in Ware County, Georgia, which is in the southeast corner of the state. This is just a little bit, some of my ladies that were involved in our research program. Yes, we do get down on the floor, and they do get back up. So it's amazing. Okay, so these ladies completed a 6-week initial pilot study looking at the importance of movement in improving your overall health and especially knee pain. And these are some of the things that we did. There was also the exercise component along with an educational component and something called motivational interviewing, which I can discuss again if you're interested. And these are my ladies. I'm so proud of them. These are ladies that completed our program. So it's important. Exercise and movement is key. So again, some more information. Again, Mayo Clinic has an excellent website on osteoporosis. NOF just stands for the National Osteoporosis Foundation. They have prevention information as well as OrthoInfo, which is actually a website from the American Academy of Orthopedic Surgeons. And lastly, and most importantly, is something called Movement is Life Caucus. It's a group of orthopedic surgeons, but also primary care physicians that are interested in advocating for movement. And lastly, if you want to, if you want to hunt me down. So I am a board certified orthopedic surgeon. I'm pretty active in the social media landscape. So if you have any questions or want to reach out or anything like that, or interested in our research opportunities, that's my contact information. Thank you.